as you said, maybe your intermediate risk or your node negative patients, despite the label, we can think about different ways of adopting this practice. And your practice has been THP for 12 weeks to see what they respond. And then do you take them to surgery? Do you do some kind of imaging or some kind of determination of whether this actually worked, or do you need to do more? How have you been handling that?
That's an excellent question. So, we certainly have data for THP now from several trials, at least good PCR data. So we saw the data from Compass HER2 PCR. I think we're usually seeing PCR rates overall around 40%, but it's the ER negative HER2 positive patients where you can really hit like the 70+% PCR rate sometimes. And it's the ER positive HER2 positive patients where we're more in that 35-ish% PCR rate. So I usually do start off with THP. I will say most of the times I do find people are getting pretty excellent responses because I'm treating smaller cancers, right? I'm not treating the very large tumors, and most of these people actually do very well. We do obtain repeat MRI imaging prior to someone going to surgery. And I think, to maybe your point, I think it now will give us a little bit of an option to potentially escalate in someone where maybe we haven't seen a good response. So maybe I guessed wrong, right? Maybe I thought this patient with a T210 tumor was going to do great on THP, and I start out that way, but turns out they get a repeat MRI and, they haven't had much of a response. That's someone where you could think about potentially escalating now, right? It is kind of the reverse order of DESTI breast 11.
That I heard that a lot, thinking about using the reverse sequence, THP first, T-DXd. I mean, what do you think about that? I'll ask a question.
I personally think it's an exciting strategy because I do think one of the challenges with these kind of blanket approaches, like the whole recipe for the DB11 regimen, all 8 cycles, is not everyone needs all that therapy, right? Yeah. And we're not so good at personalizing therapy based on biology, right? We've just made this determination, right? We said we're going to take our really big cancers and our other positive cancers and give them DB11. But the truth is that some of these really big cancers may do fine with less.
Yes.
And some of the small cancers may need more, right? Yeah. Because it is biologically driven. It isn't all anatomic risk. And I think we need to change our practice, but we just haven't figured out appropriate biomarkers to tailor therapy. I think we're getting close there. There are some really cool assays, Enhertu, maybe tailoring with ctDNA. Maybe there will be these other things, but right now, nothing is quite ready for prime time. And so I think this idea of being able to tailor based on response is helpful, but I will put a caveat in that MRIs aren't perfect. And so I think we have to be careful because particularly in ER positive disease, they are not such a good predictor of someone having a PCR or not. And so I'm not sure that that alone is going to be adequate, but we certainly have other signs. We know that person who's not having a great clinical response, maybe has had no change on MRI. That's pretty rare in HER2 positive disease, but that's someone I would think about escalating.
So I think great discussion points, great points about where we need more work, right? Like we need better biomarkers. Can we pick the right patient for the right strategy? And certainly we have examples that are in the work, such as HER2-DX, which is more prognostic, but maybe a little bit heading towards a predictive benefit piece, and maybe we'll have more. We had trials like the FERGAIN trial, where we incorporated imaging as well to identify where we could give away. Having said that, I think I was just, thinking about the THP PCRs that we see, 40%, as you said, and in the ER negative tumors can be higher. DB11 did give us the data, with just 4 additional cycles of T-DXd, 80% PCR rates, right? And HR positive, unprecedented, 61% as well. Like we definitely did better than what we have ever done before.
In a higher risk population.
In a higher risk patient population, which makes it even more attractive in many ways. Of course, the lower risk, one could strategize what we would do, but we don't know how to truly identify the true low risk from a low risk and a high anatomical risk patient population, as we were saying.